Hello, everyone. We are pleased to welcome you to this, our fourth Maryland Rural Opioid Technical Assistance Project webinar in 2021. Maryland ROTA is part of a Substance Abuse and Mental Health Services Administration initiative. It is based at the University of Maryland and conducted in partnership with local and state organizations. Our PI is Dr. Jin-Hee Kim. My name is Erin Artigiani, ROTA co-director. Barbara Kerr, Digital Media Manager, and I will be the facilitators for this webinar. Maryland ROTA aims to strengthen the capacity of rural communities in Maryland by helping our communities identify, understand, and respond to the evolving drug misuse crisis. Our multidisciplinary approach includes delivering evidence-based training and providing access to current information and local resources through the ROTA website, network, and webinars such as this. We encourage you to join our growing ROTA network to learn about best practices, access educational opportunities, ask questions of peers and experts, and share your local experiences. More information about Maryland ROTA and a link to joining our network are available at www.marylandrota.org. This webinar explores lessons learned setting up a syringe services program in rural Vance County, North Carolina. Today, we are excited to be joined by 4 colleagues from Granville Vance Public Health, North Carolina State University, and the North Carolina Harm Reduction Coalition. Our first presenter will be Lisa Harrison, Health Director at Granville Vance Public Health. She will be followed by Kelsey Accordino, Loftin Wilson, and Dr. Jennifer Carroll, Assistant Professor of Anthropology at North Carolina State University. This webinar will be approximately 60 minutes long, and we encourage you to submit questions during and after the presentations. Please do not raise your hand, though. Instead, we ask that you please post your questions in the Q&A box. We will hold a Q&A session after the presentation. We will do our best to get to all of your questions. A copy of the presenter's slides and a recording of this webinar will be made available on the Maryland ROTA website, which again is www.marylandrota.org. You can find the webinar page under the Services tab. Thank you, and we hope that you enjoy this webinar.
Thank you so much. It's wonderful to be with you all today. Kelsey is getting our slides rolling, and we appreciate the opportunity to share some of the experiences that we've had in Northeastern North Carolina, a rural 2-county public health district where we have friends and colleagues joining us today to help us tell this story. I'm Lisa Macon Harrison. I'm a local health director for Granville Vance Public Health, and we have a number of objectives today that we want to talk through and make sure that we relay. One is to identify challenges created by designing and implementing new services in the absence of input from local community members who are directly impacted by substance use and overdose. We also want to explain the importance of ongoing program monitoring and evaluation for the improvement and identification of best practices, local context by local context. And we want to describe strategies for building an effective collaboration between municipal public health agencies and not-for-profit community organizations that together provide harm reduction services. So that's what we're going to be talking about today. One of the things I think it's important to start with is just the acknowledgement that work that is collaborative in nature is going to always have some complexity. So public health does not do any of the work that is successful by doing it alone. We have to have our partners. We enjoy working with partners, and we are completely dependent over time on the different interventions that we provide in community to be work that's done together. We're just better together, and especially when it comes to rural communities, as many of you can already identify, it's just the way things work. Partnerships and collaborations are quite common and also really helpful to the work that we do. In our particular health department, we serve approximately 100,000 population, and the mission of our health department is to protect and promote health in our 2 counties. 85 staff members work across this rural district, and these sort of green circles that you see over to the right are some of the main buckets of work you can find on our website. That we do clinical services and care management, including full-scale primary care and integrated care with behavioral health. We do health promotion and wellness work in community and have a community health assessment process that we do every 3 years to help identify community health priorities, one of which over the course of the last 12 years running has included mental health and substance use disorder, addressing the needs and the services that we want to make sure we're connecting people to. Another one is nutrition and WIC, our Women, Infant, and Children Supplemental Nutrition Program. And then, of course, environmental health, which for public health departments across the nation is a core function and a lot of the reason why we exist. So mandated services for us include environmental health, vital records, and communicable disease. And certainly over the course of the last year with COVID response and vaccination clinics, many more people, I think, are familiar with the work of a health department than they were about a year and a half ago. But a year and a half ago, before all of our worlds changed quite drastically, we were doing a tremendous amount of work together with partners to address the opioid overdose concerns in our community and making sure that we were training people on how to use naloxone, that we were pulling together collaborative entities to work across law enforcement, public health, behavioral health, school systems, and many, many other partners, including those with lived experience in our community. One of the key partners who has helped us along our journey of harm reduction, understanding how to do the work well and modeling the way forward, is our North Carolina Harm Reduction Coalition. So they are a comprehensive harm reduction program. They engage in grassroots advocacy, resource development, coalition building, and then also provide direct services, including syringe exchanges, which we're going to be talking about a lot more today. They connect, and their motto is sort of no judgment. They're the no judgment zone for having trust building and human interaction relationships with respect, so that those who are impacted by drug use, sex work, overdose, gender and STI, HIV, hepatitis, different roles across all of the things that we see in public health and then some. North Carolina Harm Reduction Coalition really has led the way. And in 2015, they came to us and said, hey, we're noticing some of your numbers, and we've got some ideas about how we might work together to do what your mission is, to promote health and prevent disease. And so together we embarked on a journey and pulled together a number of partners across community called Vibrant, which was Vance initiates bringing resources and naloxone training so that we could get naloxone out into the community, make sure we were preventing overdoses. And then that led to what became our syringe exchange program. And it didn't happen in a straight line. It didn't happen with an easy path. There were some brambles along the way. And anytime you have that many partners working together on something that can be connected to politicalization or to stigma in a community, that can connect to religious and faith-based groups in the community, that can connect to workforce and business and our Chamber of Commerce and our county commissioners, and then lives inside families and inside community, it's complex. And so I'm really proud of having journeyed through this complexity together and found ways that we think have been able to change some of the stories to more positive outcomes in our community, and to really make the kind of difference that public health always seeks to make in saving lives, and in making sure that the quality of people's lives is improved. So I'm grateful that I have colleagues that share this work and share this journey with me. And so I'd like to turn it over to Kelsey Accordino to tell you a little bit more from her health promotion and wellness seat in our health department.
Thanks, Lisa. Yeah, so as Lisa said, the health department serves Granville and Vance counties, which are two rural counties adjacent to the Virginia border in northern North Carolina, with a combined population of approximately 105,000 people. So it's pretty small. The counties are rural with poverty rates of 25.6 for Vance County and 16.5 for Granville County in 2016, and unemployment rates of 6.7 for Vance County and 3.8 for Granville County as of August of 2019. We know those numbers are likely to have gone up with COVID-19. But so the region's low socioeconomic status combined with its rural economy does create an increased risk for substance use. Those counties also sit at the intersection of a couple of major highways through North Carolina. So that also increases the risk for substance use in our communities. So as Lisa mentioned, in both the 2015 and the 2018 community health assessments, which we do as part of our regular business as the health department, mental health and substance use together were identified as a top challenge facing our communities. So 43% of Granville County residents and 53% of Vance County residents selected drug use as the most important issue impacting the health of our communities in 2018. And 27% in Granville County and 38% in Vance County had a friend or family member that were affected by substance use. So the higher rates of unintentional overdose death and opioid overdose emergency department visits compared to the state, you can see those in the table, demonstrate the magnitude of the problem in the two counties. So Vance County was in the top 11 counties, I apologize, with the highest rates of emergency department visits in 2017, and Granville County was in the next highest group. So Vance County in particular is among some of the top counties in North Carolina for substance use in our state. And so with that background, we decided that it was necessary to start a syringe services program in our community. And so I'm going to turn it over to Loftin to share a little bit more about the history of that program.
Hey, y'all. So Lisa had mentioned we started collaborating. The North Carolina Harm Reduction Coalition, where I work, and the Granville Vance District Health Department started collaborating in 2015. So we applied for together a grant from the Health Resources and Services Administration to start doing overdose prevention education and naloxone distribution in Granville Vance counties, focusing sort of primarily first on Vance and then expanding to Granville. And so this was new for both partners. So for the North Carolina Harm Reduction Coalition, we had not done any programming on the ground in that region of North Carolina before. So we didn't have existing relationships with people who use drugs or community members or other coalition partners. And for Granville Vance, y'all had not done any sort of formalized overdose prevention focused programming as a health department before. So there were new things for both partners when we started the project. So there were kind of two pieces to the original Project Vibrant project that we did in 2015, 2016. So the coalition building part, which was really had the leadership of the health department, was about bringing together different stakeholders in the community to talk about overdose prevention, to talk about how it was affecting the community, and sort of work together and strategize different ways to address the issue in kind of a intersectional way that hadn't been done before. So it was bringing together public health, medical providers, treatment providers, law enforcement, harm reduction, and people with lived experience to talk about and work together around overdose prevention. And so that kind of coalition building work really planted the seeds for a lot of what we have done since then around harm reduction and overdose prevention in Granville Vance, including the Syringe Services program. And then the other piece of it was sort of the direct services piece, where we were out in the community talking with people, distributing naloxone, and doing overdose prevention education. So there were a number of different ways that we did that. So like Kelsey mentioned, there's a town in Vance County, which has historically been a distribution hub for heroin in that region of North Carolina. So there are a lot of people obviously who live in the county who use heroin, but then there are a lot of people who are traveling from nearby counties to buy heroin in Vance County, who might not necessarily live there or have, relationships there. So some of the initial strategies when we were thinking about how to reach people who are at risk for overdose, both people who live in the county and people who are traveling through the county, one of the initial strategies that we started very early on during Project Vibrant was doing outreach to pawn shops in the community. Because a lot of times when you're using drugs and you're trying to get money, pawning things is a daily reality. So we reached out to, I think, 3 or 4 pawn shops before we found one who would even talk to us. And then we got very, very lucky with one of the pawn shops that we approached because we met a woman working there named Brandy Tanner, who became eventually our outreach worker on the ground in Vance County, doing overdose prevention education and then implementing the Syringe Services program. So Brandy's a wonderful woman who is from Vance County, knows literally everybody in Vance County, knows how everybody in Vance County is, the interconnected web of relationship that everybody has with each other, is known and trusted, and is somebody who has lived experience herself and has lost loved ones to overdose as well. So someone who is very invested in this issue and very eager to start doing work in her community to address it. So early on, 2016, 2017, Brandy was still working at the pawn shop and started first as a volunteer and then as a part-time contractor doing outreach work for us in the community. And that initial overlap was really helpful because in addition to pulling in the people that Brandy was in relationship with in the community, she was also able to connect with people who she didn't know who were visiting the pawn shop and kind of have a side conversation and offer naloxone to them as she saw appropriate. And that really helped to build our relationships with people on the ground really quickly. So August of 2016, Syringe Services programs become legal in North Carolina. So our scope of work broadened from just doing strictly naloxone distribution to also starting a Syringe Services program and distributing, safer injection supplies and doing other types of harm reduction work as well. So initially we had a partnership with a community-based organization in Vance County who very kindly offered us some shared office space to do a fixed site Syringe service program a few hours a week. Initially, I think it was 10 hours a week. And so we did that for a few months. And this was in the very beginning of starting up our SSP in Vance County. And what we noticed was that hardly anybody would come to the physical location. There was still a lot of nervousness from people in the community because the law was so new. And the idea of going to like a doctor's office and saying, I need clean rigs, was a barrier for a lot of people who didn't feel comfortable doing that, but did feel comfortable talking with somebody that they knew in a space in the community where they felt more comfortable. So with that feedback from participants and from Brandy, we decided to shift from having the fixed site to being completely mobile. So Brandy spent her time meeting up with people in the community where they felt comfortable, kind of taking the motto of harm reduction, meet people where they're at, and taking that very literally. So we meet people where they live, where they work, wherever they're most comfortable, whether that's like a gas station or the Walmart parking lot or wherever, where people feel comfortable, to provide them with supplies, do overdose prevention education, and build relationships over time with people. So you can keep going on the slides, Kelsey. So a lot of the innovations that have occurred over time have been sort of a direct result of Brandy listening to feedback from participants in Vance County, seeing what worked, and letting us know what's working so that we can keep doing that. And a couple of the innovations that have worked really well for us in that context have been, Brandy does a lot of outreach to people who sell drugs in the county. So making sure that those people know who she is and know the services that she provides, making sure that they have her contact information so that they can pass it along to their customers. And then also making sure that drug sellers who are willing take extra naloxone to have on hand and to distribute to their customers. So that has been a really effective way of connecting with people who are outside of sort of the people that Brandy was personally connected to, being able to sort of expand that web of connection and connect with people who don't necessarily have the same relationships in the community, and still being able to make sure that they have access to harm reduction supplies and support. And then what Brandy calls pop the trunk, which is so during the time when she was working part-time at the pawn shop and part-time at the Harm Reduction Coalition, a lot of times she would be talking on the phone or texting with participants and would be working at the pawn shop and wouldn't be able to like come out and meet with them in person. So we set up this sort of semi self-serve situation where Brandy had supplies organized in the trunk of her car, and people would text her and let her know, hey, I'm coming through to get stuff. And then they would make themselves a bag and would text Brandy what they had gotten so she could log it out. And so this was both a way of sort of utilizing limited resources and making the most of limited staff time, and also turned out to be a really effective way of building trust and building sort of investment among participants who really felt like, you know, this is our program, this is something that they have ownership of, which was sort of demonstrated by the fact that that system like never went awry, like nobody ever took like everything in the trunk or like caused any problems with it. People were very responsible and wanted to make sure that everybody had what they needed. And so things like that that are sort of outside of the traditional framework of public health service provision, but that build community and build trust and sort of stretch scarce resources as much as possible, are really helpful and effective, especially when you're just starting out and building up programs. Yes, what's the next slide, Kelsey? Okay. I think I covered that. I think that's all for my part. And I'm going to pass it to Dr. Jen Carroll, who is one of the researchers who's been really helping us over the past couple of years with doing program evaluation and talking with participants and getting feedback in formalized ways and making sure that we're integrating all of that into how we grow the program going forward, which has been enormously helpful for us.
Thank you so much, Loftin. So good afternoon, everyone. My name is Jennifer Carroll, and I am here to share some of the outcomes of this program, talk to you a little bit about how we know this is working. I'm really grateful to not only the leadership at Granville Vance Public Health, but also to folks at the North Carolina Harm Reduction Coalition for allowing me to have a role in all of this process. I feel, you know, I am an independent researcher, so I feel really privileged to be able to collaborate with them, learn from them, work with them. And also, I think I've said this to folks before, but one of the reasons why I wanted to move to North Carolina in the first place is because some of these organizations have such a reputation before them. I was like, yes, NCHRC, USU, let's go. I'm so excited to work with these folks. So, I was able to do some math with the numbers that they so diligently keep for part of their state reporting. And what's been really exciting is over the last 3.5 years, these numbers ended in December 2020. That's when we last did the arithmetic. But there has been a 10-time growth in the number of participants served from 39 in 2016 to 375 in 2020. So there's a huge expansion of just the people who are getting connected with, let alone huge rates of individual contacts. They have distributed more than 330,000 syringes and had almost 160,000 syringes returned for safe disposal, which is really excellent. One of the major benefits that syringe service programs offers to communities, which is very well demonstrated, and I think we all know, is that it is able to so dramatically contribute to a lessening of things like syringe litter, unsafe disposal. Plenty of people are actually able to dispose of syringes very safely on their own and do not need to rely on the syringe service program for that particular service. But it's a really great opportunity for folks who have challenges in that regard. They've distributed over 6,400 naloxone kits, and out of those 6,400, at least that we know of, 813 have been returned for, or have been reported back as used for a community overdose reversal. That's 1 for every 7 to 8 kits distributed. If you are working with an SSP in your area, you know that that ratio is really hard to hit. That's deeply impressive, because one of the things that SSPs are particularly good at is identifying folks who are the most likely to have to use something like a naloxone kit. They're the most likely to witness an overdose, be proximal to an overdose overdose. And they're just doing a really, really excellent job at narrowing in on that community that needs to have access. There's much, much stronger interagency partnerships between Granville Vance Public Health and NCHRC. Obviously, I think the fact that we're here today is an example of that. And what really impressed me in particular about this collaboration, which was already up and running when I showed up and started building my own partnerships with these particular folks, is that the division of labor that is offered, and this is something that Lisa and Dr. Harris talked about as well, that the division of labor really relies on the strengths of the different partners. And this is something when I first started meeting folks and learning how things run at this particular program, this is something that Lisa said to me, this is something that Loftin said to me, like everyone is kind of like, oh, thank God we have the other player to help provide us support. And there's a lot of trust that goes along with that. Something that Lisa said to me actually very early on in my learning process is this quote at the bottom, that this is what rural life already is, you know, getting people together and building that farmhouse. Next slide, please, Kelsey. All right, so this is a visual representation of the number of syringes returned for safe disposal. I mentioned before that it has been almost 160,000 as of December 2020, but I wanted to give you a sense of what that looks like in real life. One of the things that Loftin indicated was that a huge amount of success that Brandy has been able to have is predicated on the trust that she has in the community, and not just trust for being a really nice person who's very approachable and very easy to talk to. She is all of those things that makes her a very skilled and appropriate person to be doing that job. But she also is a known person, and she is someone who has shared experience, and she's someone that people know are going to get them and understand where they come from. Despite that, it can be really scary for people to participate in some of these programs, especially if they're coming around for the first time, especially if they need to learn through experience that they're not going to get in trouble, if they need to learn through experience that involvement with a syringe program is not going to result a week later in law enforcement showing up at their door. You know, people have their own reasons for having that fear and harboring that distrust. So building that trust, not just between the individuals, but in the context of the program, is a really, really key element early on, and it takes time. And so what I've done, if this doesn't make you too dizzy, I hope not, I've kind of broken up our bar graph here into the different stages that Loftin was just talking about. So on the very, very far left, we've got the fixed site at 10 hours a week, and you're see like there ain't nothing doing, like nothing is happening over there, no one's showing up. Once they move over to mobile, they actually get a lot more activity. They start seeing a lot more people, they start enrolling a lot more folks. But I want you to look at these numbers. It took from June to May to actually start really getting syringes back on a significant basis. And what I interpret that as is this is the time when Brandy was building that trust. And then I spent a lot of time actually working in Eastern Europe, and one of the phrases that we often tell ourselves is sort of to boost our spirits when we're feeling a little frustrated trying to get going and meet people locally is that, until you're in, you're out. Right? It just takes time to get people to trust you, to work your way in, to be in the conversations, to be invited in the room. And we see that it took about a year for Brandy to get that in. And then as soon as that trust was there, the numbers just exponentially increased and people started feeling comfortable using that services. And it's not like it was a slow growth over time. It's just one day it clicked. And that's something that we see a lot. And so what I want to really hope that you appreciate from this particular slide is not just how much time it takes to build that particular trust, but also what that trust is capable of producing once you make the space for people to join into those relationships. Kelsey, next slide, please. Thank you. All right, so this is a different slide that shows you actually the ratio of syringes distributed to returned monthly. So in the numbers I showed you previously, there were about 330,000 syringes distributed, about 160,000 returned. That's a little bit less than a 50%, a 2-to-1 ratio going out versus coming in. But also this changes dramatically over time. And so you can see at the beginning, even during the fixed site, when they were still getting some syringes out the door and still getting some syringes in the door, there was not a lot happening, right? And then it grows and it grows and it grows. Right before COVID hit, the arrow that's pointing to this, it's December 2019, they actually broke 100%. That month, they brought in more syringes for safe disposal than they actually distributed out. And of course, things always fluctuate. You're not, even in this really strong program, you're going to see like November 2018 really low, and then October really high, and then That's just, how people work. But I wanted to point this out and say a couple of things about it. I have been working with syringe programs across the country for a really, really long time. This is my area of expertise. And I've been looking at how they operate, what they're capable of accomplishing, what the public health and public well-being impacts of those accomplishments are. And it is extremely rare to see this, right? So I want to emphasize to you that this is not reasonable and that it's not appropriate to go home and be like, hey, local syringe exchange, how come you're not getting 105% of your syringes back in? Because that's wild. I've never seen this before. But what I think is pretty remarkable about this program is the degree to which leadership both at NCHRC and at Granville Vance Public Health was willing to follow through on letting Brandy use her expertise. NCHRC needed Brandy's expertise as someone who had lived experience in the community, and Granville Vance Public Health needed Brandy's expertise as someone who has lived experience in the problems of the people that she's serving, right? And truly removing barriers from her, not getting in her way, allowed this to happen. And I think that's pretty extraordinary. So this is what can happen when we are able to truly recognize and center what is expertise. And I want to emphasize that one more time. So especially when it comes to how we look on paper, I have multiple advanced degrees. I have a PhD, I have a master's degree in epidemiology. I get labeled as an expert a lot of the times where I go. And yet I know better than anyone else that the most effective, wildly impactful programs that we have to manage not only the health of people who use drugs, but the health of the entire community in which some people do use drugs have come from people who use drugs. Like off the charts, things that we need to change the y-axis for are syringe access, naloxone access, safe supply, safe consumption. These are all things that were designed by people who use drugs. No one like me came up with this. No one like Lisa or Kelsey came up with this, right? It's folks like Brandy who know what they're doing, and this is what they're capable of doing if we just stop getting in their way. Next slide, please. All right, and so I just wanted to emphasize this one more time as well. On the top going up, you see the number of naloxone kits distributed. On the bottom, you see the number of overdose reversals reported. And so I've already said that 1 out of every 7 to 8 naloxone kits distributed gets used to reverse an overdose in Granville Vance County, which is pretty wild in and of its own. But these trends are interesting, right? You see, especially right around that time, May, June 2018, when Brandy really starts to be able to capitalize on the trust that she's building community, she just starts saturating the community with naloxone, right? And the numbers are huge. Over time, it tapers off. And that's not because demand is decreasing, or as you can tell from the bottom, it's not because the utility is decreasing. Overdoses are still happening. This is what the trends look like when you are really effectively getting naloxone into all the social nooks and crannies where it needs to be to help prevent totally accidental, totally unnecessary preventable deaths when someone has an overdose crisis. I think this is an important slide to think about when you are planning the logistics of a syringe service program, when you are planning the finances of a syringe service program. You are going to have, if you're doing your job well, you're going to have a May 2018. Right? And you're going to have a month where stuff is flying out the door and you just need to be able to cover that demand. Okay, next slide, please. All right, so as Loftin mentioned, I have had the extreme privilege of getting to shadow some outreach workers and talk to folks who have been building up this community and being part of the Granville Vance Public Health and NCHRC syringe program in this region. And this is what some folks told me, especially when I asked them about trust, right? About what trust means for them and how it's helping them participate in this program. What I really learned is that trust is, of course, essential, but that it cannot be earned by everyone, right? So for example, I am also a very nice person. I tend to be very easy to talk to. I think I'm pretty funny. And so even though I have personality and people skills that would make me a pretty okay outreach worker, as someone who doesn't know the local community and doesn't know the local scene and doesn't have local experience, I would not be anywhere near as good as Brandy. And one of the reasons why is because that kind of trust is just not something that I can earn in the same way. So folks told us, quote, I know you can go to the fire department and stuff and get Narcan and shit like that, but it's just, we know Brandy, right? When we're comfortable with her, it's more of a comfort thing. We know her. And someone else said, I've heard the health department gives out Narcan. I don't know how true that is. I mean, it's awkward to just go anywhere and be like, I need Narcan. But with Brandy, we know Brandy. She knows what the F we're doing. She don't judge us. right? And that was repeated over and over and over again. I don't believe that anyone at the health department is judging them either, but they don't expect Brandy to judge them is also really big. Okay, next slide, please. All right, and this is another conversation I had about trust when I asked, do you think it would be helpful to have more than one Brandy doing outreach? Like if we could clone her, would you prefer that we do that? And the immediate response I got was, it has to be someone who uses. And then someone else followed up and said, yeah, you got to understand that people trust other people that do dope. So when it's me and my friend and come through with rigs and Narcan and stuff, and they're talking about supplying other friends secondary exchange with equipment, they're like, oh, they do dope too. So it's cool, right? So that is a really, really essential element as well. Next slide, please. All right, and so these are the final takeaways. So if you remember anything from this presentation, I would encourage you to file one or all three of these things away in your mind, because this is really the message that I would like to leave you with from the last few slides. So one is that rural harm reduction and overdose prevention can be very effective without becoming politically or financially expensive. Right. So what that equation looks like in your particular community is going to be, I mean, you're the expert on that, right? And so we have a lot of folks here with a lot of experience to be able to answer questions and talk through things, but you're the expert in your community. So understanding what that looks like is a challenge that each local community kind of has to go through on their own, but it is possible. It's very, very, very possible. So don't give up. Two, essential harm reduction and overdose prevention programs can be direct service, which means a human being takes supplies out of the supply drawer and physically hands it to the participant. Or you can do a lot of other things. Novel self-service programs can remain very, very effective. I think Brandy's Pop the Trunk program has shown us that. We know of other places in the United States where folks are experimenting with vending machines. So where people can sort of like distribute out syringes, fentanyl test strips, things of that nature. There's all sorts of ways to innovate, right? We don't have to be stuck in this singular, stop by the drop-in center or have the, outreach worker be the Avon lady that goes from door to door. Those are tried and true methods. They really work, but there's a lot of other ways to imagine this happening that can be just as effective. And third, individuals who are directly impacted by substance use are needed in leadership positions. And I want to emphasize in leadership positions. So we do not want people who are directly impacted by substance use to be on advisory boards. We do not want them to be, de facto members of particular groups. We want them to be in decision-making positions where they can influence program structure, where they can influence program goals, or where they can influence program implementation, because that is where their skills lie. Right. So it's more than just listening to constituency. It's acknowledging that the real expertise does not belong to people who don't have this kind of experience. It belongs to people who have that kind of experience. If you have someone in your health department, on your board who already has that experience, great. But a lot of us don't. So we need to proactively put those folks there. And that is what I have, I believe. I think our next slide is Q&A. Yeah, thank you all so much for your time. I really appreciate it. And I think we are going to be happy to answer your questions. I know, but I believe we're going into Q&A.
Yes, we will switch over to Q&A now. So thank you so much for the presentations and all of the information you shared. That really was incredibly helpful and insightful. And I'm sure we will have some questions. It looks like, though, we might be having a bit of a problem with the Q&A box. So because I don't see anything showing up there. So if you have questions or comments, you also should feel free to put them in the chat or raise your hand, and I'll see if I can find a way to get in touch with you that way. And in the meantime, I just wanted to follow up with a question that I had. I found it really interesting following your slides. And I certainly really appreciate all of your comments about the importance of recognizing who the real experts are and making sure that you include people with that lived experience in leadership positions. And certainly that's something we've been talking about with the rural Maryland counties that we work with as well. But I also noticed you had some information in there at the end of some of your bar charts on COVID. And I'm just wondering if you noticed, I mean, it looked like things were really going well up through 2019, and that the switch to mobile had made a big difference, and you were starting to reach a lot more people, both getting syringes out and getting syringes turned in. And I'm just wondering if you noticed any changes during COVID. Were people actually more interested in reaching out to the mobile service because they had less access to other services, or were they less likely to come out, or were there changes in what they were doing or how they were doing it?
Sure, I can speak to that. So, and Jen can probably speak to it more specifically on like a data level, but just experientially. So one of the benefits actually of being primarily mobile is that we never had to stop or disrupt services, even in the like very beginning height of the pandemic when a lot of things were shut down, because we were able to operate safely by having meetups, you know, outside, mask, social distance, offering people the option to drop off supplies on their porch or things like that if they weren't comfortable meeting in person. So we were able to keep services operational throughout the entire pandemic. But there was that first spring and summer, there was some wild stuff. And that is reflected, I think, in the data. And a lot of that had to do with both, you know, disruptions in people's lives, economic disruptions, people getting sick, people having, you know, all the stuff that comes with COVID. And then the global piece of the entire global drug supply being disrupted and altered in a really profound way, which really made some crazy spikes in overdose risk that we saw throughout, particularly that summer, where there would be periods where the drug supply was very altered and stepped on, and there were very low rates of overdoses, and then huge spikes when the supply shifted and there were many reversals. But yes, but I think the flexibility of being community-based, being mobile, that really helped us respond to the pandemic, and also to kind of not only keep the harm reduction services consistent, but also be able to kind of weave in COVID specific stuff. So doing a lot of distribution of masks, a lot of education and connection to vaccines. We're actually able to offer COVID vaccines to participants directly on mobile exchange through a partnership with Dr. Guthrie, who is the medical director of Granville Vance, and then also has her own private practice. She very kindly agreed to ride along on outreach and do vaccines directly with participants. So vaccinating people who would probably not have gone to you know, the health department directly to get vaccinated, keeping that accessible for people. So
That's great. Okay, thank you. Our next question, is there a significant difference in the syringe and naloxone distribution statistics between the two counties you cover? Is one more successful or different in some way than the other?
So I do not believe that we have actually looked at that data, because we don't, as far as program implementation goes, at least I don't perceive of the county line as being significant. It's all an area covered by the services. So I do know that we have data that's disaggregated, or we had the data is labeled by location most of the time, but I've never actually disaggregated it. But you know, I think it's important to note that the public health department operates across both counties, and NCHRC operates across both counties. And so I would anticipate difference would be more around where the larger population clusters are, which is kind of secondary to the county, but Loftin would have more insight as well as Lisa, I'm sure.
And also important to, so we're based in Vance and Carroll counties, but we also have significant numbers of participants from neighboring rural counties of Warren and Franklin. And it is all kind of like the 5-county region. So it is very like, you know, there are differences between the counties, but it is, I would say, more of a region than a clear cut like difference between the counties. And we did start disaggregating by county, but only like a couple years in. Like I think we started implementing the like adding a county identifier to the unique identifier, I think in 2019 or early 2020, because we were curious to just start pulling apart in that way, but we haven't done anything with that. That would be interesting probably at some point to analyze.
All right, thank you. We have another question. How successful have you been in motivating PWID to serve in leadership roles, and how have funders and local professionals perceived them as leaders and experts?
Well, I think Brandy's a great example of how, people with different substance use experience have been able to be active in our coalition work, and then their own leadership actually sort of emerges. I mean, I think it was fun to get to know Brandy through our Vibrant coalition that we started early on. And then, over time, this was something that she's just been so passionate about, that everybody that I am familiar with who knows of our work and knows of Brandy is very accepting of her in this role and really grateful for what she's accomplishing. So in this situation, and with the relationships we've been able to foster through our coalition, including law enforcement who are well aware of what we're doing and supportive, which can be surprising to some people in other areas who might not have that same relationship. And I recognize relationships are as Jennifer pointed out, really critical to build and build that trust initially. But we have not seen any particular negative blowbacks or issues with Brandy being in charge of this. And Loftin, you might have other examples, but I have not known of any.
And I just wanted to add that I think that is an enormous part because of this collaboration that we have, and how enormously helpful it is when there are people with lived experience taking leadership roles to have very strong, involved community partners like the Granville Vance Public Health Department, who are, seen as legitimate and respected, because it makes a big difference for, when we're having meetings with stakeholders and law enforcement and treatment providers and all that stuff. Like if I say something or Brandy says something, that is listened to in a different way when it's coming from, these are the people that the health department respects. So being able to have that buy-in, I think is really, we would never have been able to accomplish what we've accomplished without that partnership and that buy-in. And that question also came from our friend Neil Carnes. So I wanted to say hi, Neil.
So we have one question here. Are many of the people that participate in the syringe exchange and the naloxone distributions in these counties uninsured?
Yeah, and we'll have to look at the data again to be able to correlate all of that more officially, but just in general knowledge, yes. People often are able to receive health insurance when they are also associated in the working world. And a lot of what we've learned in our medication assisted treatment program that Dr. Guthrie runs, our medical director that we were talking about, one of the missions most people have in their treatment and recovery is to be able to get back to work to get their health insurance back so that they can continue on, the path to the recovery in a way that doesn't break them. And so we work very closely with the uninsured. And of course, that's part of the safety net mission of a local health department. So we're familiar with doing that work.
And we're a non-Medicaid expansion state, unfortunately. So that means that a lot of people do not have access to care.
Thank you. Do you have a homeless population in your two counties? And if so, were there any special outreaches to them or any particular lessons you learned in working with them?
Yeah, no, definitely. So Kelsey and Lisa are the experts on like what the prevalence is of homelessness in the counties, but definitely I think another strength of being of building relationships and being mobile and being out in the community is that we're able to connect with people who are in precarious situations, like being unsheltered or unstably housed. And a lot of our participants who, in an ideal situation, we maintain relationships with people over a long period of time. Like there are participants that we see, every week or every couple of weeks for years. So being able to kind of stick with people and maintain that positive relationship as people's lives kind of go through ups and downs and cycles. And one of the biggest things that as an outreach worker, I see contributing to sort of increased chaotic use is when people's housing situation changes and they don't have a stable place to live. That can really be kind of the pin that you pull it out and everything else kind of falls apart. And that's a big issue, especially because like a lot of rural counties, there are very few emergency shelter options for people. So there are a lot of situations where people are sleeping in cars or they're sleeping on, their friend's property or outside or in abandoned buildings and things like that.
Yeah, I was going to say we don't have any emergency shelter options in Granville or Vance counties. So that makes the mobile piece of the Syringe Services Program particularly important because it allows Loftin and Brandy to be agile and meet people, as Loftin said, where they are, right? And so that might mean that they were at one residence 2 weeks ago and they're at a different residence now. And it's really easy for them to still access Loftin and Brandy without barriers.
Yeah. Well, one quick thing I want to mention is that if you are experiencing a lot of vehicular residency in your area, and that is something that you are just expending a lot of effort trying to figure out how to count, how to assess, how to respond to. There is a particular individual who I would recommend very, very highly. He's also an anthropologist, so I'm kind of partial to him, but his name is Graham Pruss. He just started a postdoctoral fellowship at the University of California, San Francisco, and he is, I think, probably the best expert in vehicular residency that we currently have in the United States right now. And he's also very nice and answers his DMs a lot. So Pruss is his last name, Graham Pruss. Definitely reach out to him for insights, because I know he completely 180'd the way in which King County and Washington State was managing their one night count, things like that. And he's now, turning over a lot of tables in San Francisco. So an enormous resource.
Have you guys worked with peer recovery specialists at all as a part of this program or your harm reduction efforts?
Yes. So there's kind of two answers to that, Bill. Yes. So everybody, like we had mentioned before, not just in our Vance Granville program, but across the state, we really emphasize people who are leading, designing, implementing these programs being people with lived experience. So peers in the broad sense of the word. And then in the more specific sense, there's a statewide peer support certification here in North Carolina. I assume there's a similar thing or the same thing in other states, which can be kind of just a more formalized way for people to have a piece of paper that says, I have expertise in this. And some folks who do harm reduction work have that certification and some don't. As a group, the Harm Reduction Coalition, we try not to put a lot of emphasis on that versus just the person's skills and abilities in general. But it is an option for people to have that certification as kind of an additional thing to show.
I think what's important in working with peer support that we've learned is that it's nice to have a group like Harm Reduction Coalition who have sort of a supportive network of individuals who understand some of the challenges of living in recovery and staying in recovery. Not every entity, not every health department, not every law enforcement office is going to have the same skill set in being able to support people through some of those challenging times that might waver that recovery or might not make their work in this realm as effective. And so I think that's another point back to the partnership as to how effective it is to work with a harm reduction coalition and a not-for-profit like they know how to do. And in addition, we also have peer support specialists embedded in some of our behavioral health entities locally, and they help a lot with our Stepping Up initiative, which is our work around mental health and substance use disorder in the jails and providing case management and connection to services for folks in our jail systems across these 5 counties in the region. And so peer support, we've tried to place in different areas, and we just find it's really helpful to have it embedded in behavioral health and have enough support for individuals to keep the connections going and to understand what's expected of them on the work side.
All right. Well, thank you so much, everyone. I really appreciate the presentations and all of the information you shared. I think we had a good discussion here this afternoon. And I think we'll put up again our slide that has your emails on it in case anybody is interested in following up with any of you. And I hope also that we'll see many of you again at our upcoming webinars. We have 2 planned for July. One will focus on the impact of stigma, and the other will highlight the results of an analysis that was done comparing overdose trends in urban and rural communities. So keep an eye out for our announcements and the registration information for those as well. And thanks again to everyone for joining us today, and enjoy the rest of your afternoon.